So my name is Shubs. I am a former GP from the UK. I spent the last 7 years working as a medical director at Ada Health, which is a symptom assessment tool. I was working on our quality frameworks, the communication of our evidence. We had deployed to health systems in the US, in Europe and Africa. I've also worked as a clinician with community health workers in Sierra Leone. And a year ago, I created a podcast, and the angle of the podcast is what can we learn from people who are implementing AI and digital health with underserved communities, and particularly in low and middle income country settings. The reason for that is because we don't really see that conversation. I mean, this is an amazing kind of bringing together of people. And actually, it's great because there's a few great examples of people who are working in this space. But we often, when we talk about regulation, when we talk about innovation, the angle that we think about that part of the world, which is actually where most people live, is, how do we take this tech and have an impact there? But actually, one of the things I've learned from working in this space and from meeting people when I've done some work with the WHO is there's a lot we can learn about good implementation and good co-design from people who are implementing in this space. So that's what Global Perspectives on Digital Health podcast does, and brings out policy and people innovating on the ground, and what do we need to do to implement well.
Super cool. It's great to be able to chat with fellow podcasters.
Yes, exactly.
And I feel like we've talked more at this event off microphone than on,
sure.
But it's good to be able to connect right now. And you've been up on a stage, is that right? You were moderating a panel, I think?
Correct, yeah. So it was on the first day, and it was in conjunction with Doctorpreneurs, which is I'm not affiliated to them, but they're great friends of mine, and they're helping clinicians with careers in tech. And we were talking a lot about, yes, I mean, at the moment there's been this massive proliferation of opportunities for clinicians, particularly in the UK and Europe, to work and have an impact and shape good adoption and actual clinical outcomes, which are hard to get in this space, right? And so, how do you make sure that clinicians are integrated in the right way? And so, whilst I would say, having worked in this field for the last kind of 8 years, at the beginning, anyone who would look at a startup, a clinician, they'll be like, "Oh my God, someone's talking to us. This is great." Yeah. And now it's clinicians are like, how do I differentiate myself? There's so much competition. Yeah. Do I need to learn how to code? Do I need to learn how product people do things? Do I need to? And so this conversation with some people who have really been in the field, we're actually talking more about the good, the bad, and the ugly. What's hard about integrating? There's sometimes overlapping roles and responsibilities with product teams. Sometimes clinicians in digital health companies are seen as slowing things down. And so we're trying to think about why is that hard? Actually, that's not always the case. Sometimes clinicians can help create, here are some guardrails, and within these you can absolutely go fast, right? And so how do you do that? How do you operationalize that? That's what we're talking about.
I find that's super interesting because from my own experience of working in digital health startups in that kind of 2015-16 onwards era, you're right, is that if there's any clinician that kind of remotely took interest in participating, you're like, cool, regardless of your background. It's this is what we do. And that's definitely shifted these days. I'm just kind of reflecting on that point that you made, though, of I can totally see how that comes about. Often the culture of an organization I've seen is where they'd bring in the clinical person almost more so as a safety, plug a hole and demonstrate, hey, we got to doctor someone on the board or within the business because we're a health organization. And often then to that individual, that may then feel like their responsibility is to either, slow things down, make things more just not rigorous, but almost just adding additional controls for the sake of controls.
Yeah,
it's that extra step of bringing them into the clinical, bringing the clinical into the whole kind of DNA of how an organization runs. Much easier to say, much harder to do. But it sounds like there's examples of organizations that have done that, as opposed to having that notional clinical advisor where they might flick an email once a quarter and say, "What do you reckon of this?" So it's quite different.
Absolutely. I mean, 100%. Moving your mindset and shift to. I think there's a parallel with legal teams in companies, and often I know a few folks who are legal, and they kind of, when I've talked to them about the problems that I've lived, they're totally the same for us. And so What I think the concept is, what like anti-pattern is, hey, we built this thing, let's like get a clinician to like verify and check it meets it, and then, but inevitably that will slow things down, because totally the clinician will be like, hold on, why is this like this, when actually
and then
you had an assumption.
Why did we ask that?
Exactly. And so, and that's literally what happened to me when I was working at Ada. And so I was like, and Ada was a great place to do this, because Ada was like one of the companies that like leaned into like the ground was fertile, because they were leaning into EU MDR regulation back in like 2019. And so this was the place where we're like, hey, let's really think about how we can do this. And actually the ROI back for us to invest in this effort is kind of how the Marines say, like, slow is smooth, smooth is fast, right? So where do we need to slow down, and where can we still go fast? And if we can define that together and actually have clinicians to like make sure our assumptions are kind of right, make sure we're actually working on the right bit of the problem, understanding really right at the beginning, like, what is the risk of this use case? What is the risk of this context? And then like actually working with our design team and product team and engineering team to like, okay, we've got a really good hypothesis on how we can like mitigate this. And then we had clinicians who were working with our quality engineers on actually testing it. And so we had high confidence before deploying. And then you need the after deployment, like quality improvement loop, where you can then analyze the data with a clinical lens, not just a product lens. So bring all of that together to like, okay, here's what we need to focus on improving. Here's what's kind of falling off. And that really matters to the value that we're creating. Getting that right, people then saw the value of like, oh yeah, like actually it is worth investing our time in getting this right. So yeah, we didn't always get things right all of the time. And there was lots of pushback initially on the process. And so I think another takeaway was, don't build a process until you first built relationships. So take the time to understand how our product managers are making decisions in that context, how engineers are thinking, how the design team are thinking. And then you're like more able to like actually learn, wow, that is awesome. Actually, that's I hadn't even thought about it that way. Actually, if we apply this to now how we frame this in this clinical context, wow, actually we initially thought about this in a very limited sphere, but actually it's opened our minds in some ways. So anyway, might seem a bit esoteric, but it can happen like that.
Yeah, it's important going in with that mind frame of like, it's may break the mold of what you're currently thinking, but that's sometimes the whole point. Last big jobs, I've been thinking about like, you know, where your passion lies at the moment in terms of, as you mentioned earlier, application technology, digital and AI into, I guess, underserved communities or areas that need it. Because I often think this too, is that where we bleed this line sometimes of, at least where money goes, sometimes money in digital health or more broadly wellness and longevity goes in from people who have a hobby of measuring every metric they have, you know, in this bucket of the worried well, to then further invest in their hobby of measuring all their metrics, calling it AI in healthcare, and then kind of retrofitting and saying, well, this is serving, everyone in the community, when in reality, someone who lives in Western Sydney doesn't really care about the how much REM sleep and every other kind of level they have. Ultimately, they're managing chronic disease, or they need to get a doctor's certificate so they can go to get paid because they didn't get to work today. So I feel like this gap between like what healthcare needs and where we put money into, and sometimes, not always the case, but it can sometimes be this thing. And often the technology say, well, let's put some more technology into the area that needs it. But it's not even digital literacy and access to technology and all those things. I just feel like sometimes we're a little bit, hammers looking for nails in terms of like, where can we put this to make us feel a little bit better about these things?
Yep.
Are there examples of things you're like, well, hey, look, this is actually, we're doing things at scale? Because I do see there are examples of, that argument of potentially in underserved communities or nations where they don't have access to anything, so potentially access to AI is access to something better than no one.
Yeah.
But that I find is also a really interesting concept.
Oh man, you've touched on so many things.
It wasn't even a question. I was just telling stuff.
No. Okay, let me riff off this. I have lots of strong and sometimes maybe unpopular opinions about this, but I think a few years ago we were really well disciplined about, generally, like, I don't want to generalize too much, but generally people understood, okay, work backwards from the healthcare and transformation goal that you want to achieve, and then think about work backwards from that. Okay, and how might we do that? And think broadly from a systems perspective of what interventions will work. And within that, there are opportunities to use technology effectively. But actually, much of it might be actually people innovation or systems design innovation.
Yes.
We forget that. And so I see so many examples of us somehow regressing to now, because of like FOMO and vibes. This is a once in a generation opportunity.
Yeah. We've had like 5 once in a generation opportunities in the past 10 years.
Yeah, and it kind of is, but LLMs have become a goal again. Like even multilateral organizations who should be kind of thinking about this better. I don't want to name any names, but we all do. We all do it to some degree. So it's not about someone. It's all of us, right? Instead of let's get LLMs into this underserved setting, it's let's actually think about how we want a really good healthcare experience and healthcare delivery to look, and work backwards from that. And yes, then you will have like the right problems and the right use cases to say, oh, these are the ones where like we talked about the guide rails and the things like where can we move fast?
Yes.
Those are like the problem spaces where like, wow, okay, let's really explore this. And so I think, yes, let's do LLMs in healthcare, but let's attach it to an actual end that everyone agrees with, basically.
Yeah. No, I like that.
So,
hey, lastly, because we should wrap so we can do more things, but any other final thoughts, takeaways, stuff you're taking away from Health Europe specifically that you'd hope? Because, in the end, the best outcome of some of these events is people don't just leave the conversations here at the exhibition centre.
Yeah.
We can apply some things back into home. Is there anything you're seeing that people might take away for betterment of the ecosystem?
Yeah, I mean, so of course, like one of the big takeaways that people came up to at the session that we had about clinicians in health tech was like, oh, thank you for sharing what's hard about it. So we talked about failure, we talked about what's hard. So I think that's a really good takeaway, that it's great. Health is such a great lighthouse of how to do a conference well. And I would love to see more conversations about what's hard. We do, as an ecosystem, need to create the ecosystem level psychological safety to make it okay to talk about that. Like, how will your investor let you talk about what you effed up on, right? That's hard. But I feel like there is potentially protected spaces that we can talk about what's really hard. So that's one. And two, I've been roving around and finding a few really cool examples of people who are here at Health Europe, who are creating impact in Africa and India. Oh, cool. And so I'm kind of trying to do a little segment in letting them talk about what they're doing. Yeah. And I would love to see more of that, a track about that. I know it's Health Europe, but we have so much to learn from each other. Why don't we have a track where there's actual innovators, community health workers, people coming from these settings who can teach us a thing or two about what's going on there?